Welcome to this Physicians Anonymous Grand Round held on October 6, 2025. Physicians Anonymous is the only free, confidential, and anonymous peer support platform for physicians and medical students. By providing safe spaces, we reduce physician burnout, isolation, and suicide. We are a registered 501c3 not-for-profit, so donations are appreciated. Check out physiciansanonymous.org for more information. Today's talk is titled Better Outcomes Without Resources, Lessons from Positive Deviance in Medicine, and is presented by physician coach and group facilitator, Dr. Jeff Cohn.
So Nasruddin is a former Sufi, was a Sufi mystic from like the 1300s. And he appears in many stories, often in different guises. In this particular story, Nasruddin is a wealthy merchant who is suspected by border guards of being a smuggler. Each day he leads a caravan across the border, piled with bags filled with various goods. And each day he returns wealthier and wealthier. One of the border guards particularly is suspicious that this is because he's smuggling something, but try as he might, day after day, week after week, month after month, year after year, he never is able to find what Nasruddin is smuggling. So he gets richer and richer, and the border guard becomes more and more frustrated. Finally, decades pass, and both the border guard and Nasruddin are old men who happen to pass each other on the street one day. And the border guard stops him and says, Nasruddin, now that we're old men and retired, and I can no longer harm you in any ways, could you please help an old, frustrated man like me? I know you were smuggling something, but I could never figure out what it was. So please, could you please let me know what it was all those years that you were smuggling? And with a sly grin, Nasruddin says, well, it's obvious. I was smuggling donkeys. So positive deviance is about solutions that are hiding in plain sight. That's what the story has to do with positive deviance. Here's the definition of positive deviance, or as I'll be referring to it throughout the rest of this talk, PD. In every community, and define community however you wish, but it needs to be people who really think of themselves as a community, could be by geography, by common interest, by where they work, what their job is, but they think of themselves as being part of a group. And in that group, in every group like that, there exist individuals who have uncommon practices. They're practices that differ from what the norm is, that enable them to get different and better outcomes than their peers, even though they face the same barriers. So they're not set up for success. And they have no extraordinary resources. They don't have more money. They don't have special skills. The things that they're doing are available to everyone. This term PD came to people's attention in the 1950s when nutrition researchers went into tenements, stratified people who lived there, families, by degree of poverty, poor, very poor, very, very poor, and found that even in the very, very poor families, there were sometimes well-nourished children. They referred to these families as being positively deviant, and that finding sat in the nutrition literature for decades. In the 1990s, two nutrition researchers from Tufts, Jerry and Monique Sternin, who also did volunteer work for the Save the Children Foundation, were asked to come to Vietnam where children were dying of starvation. They came, met with the Minister of Health, who said, I'm so happy that you're here. We really need your help. And I've got a visa to give to you, which will be for the next 6 months, allowing you to be here and do this work. And Monique and Jerry said, 6 months? That's crazy. We don't speak the language. We've never been here before. We have no connections. We can't possibly do anything except just get started in 6 months. He said, well, my country is still under an embargo from your country. So 6 months is all I can get you. So please do something in that period of time. So they went to the first village and they remembered the positive deviance finding from decades before and found lots of malnourished kids in this village, but did find that, yes, even in the very, very poorest families in this village, there were some well-nourished kids. And then they did the subtle but critical behavior that turned this from an epidemiological finding to a change methodology. They said to the families whose children were malnourished, let's go see. Let's go to the huts of the well-nourished kids and find out what's happening differently. Now, the community norm was to feed these little malnourished kids full bowls of rice twice a day. And that was what they ate. And as they started interviewing people in these huts, some different practices surfaced. Whenever they heard something that was different, they would hold it up to the group and say, could you do this? What do you think? And if anyone said no, it went on a list that they called TBU, true but useless. So these practices had to be truly available to everyone. And a couple surfaced that were. So, like I said, the staple for the entire community was rice, but the little malnourished kids with shrunken stomachs couldn't eat a full bowl of rice. And whatever was left over got thrown out because almost nobody had any refrigerators. But in the PD families, they wound up giving the kids a half a bowl of rice 3 or 4 times a day, and less rice got thrown out and more rice got consumed. So that was part of what seemed to be a local solution. In addition, the adults in the village mixed into their rice shrimps and other crustaceans that swam in the rice paddies, as well as the tops of turnip greens that also were nearby the rice paddies. But most families felt that this was inappropriate for children to eat. But in the PD families, the kids were getting these things too. So the parents of the malnourished kids said, yeah, we could try that, but we would need some help getting started because we've never done this for our children. Could you help us learn to do this? And so Jerry and Monique said, sure, we'll stick around for a week, which they did, and kind of coached them to build these new habits. And then they left, never to return to this village again. 3 years later, workers from another non-governmental organization came back to this village and learned that 85% of the previously malnourished kids had become well-nourished. And none of the siblings born into their families since the Sternans had been there ever became malnourished. So basically, the problem was solved for free from solutions that had already existed within that community. And then to the Sternans' credit, when they went upriver to the next village, instead of what you might seem like would make sense to do, instead of saying, hey, guess what we learned downriver at the next village downstream from you, they started the process all over again. Because if they told them what the other villagers were doing that were working, that could generate what Jerry Sternin called the organizational immune response, or what he said, the yeah, but response. Like, yeah, but they can do that there because, and then people would make up some reason. So he avoided that happening by starting over again and discovering what was happening in a PD fashion in that village. It might turn out to be the same, it might turn out to be different, but it belonged to them, and that avoided that immune response. So fast forward a decade or so later, I was the chief quality officer at Einstein in Philadelphia, and I got invited, like everybody in the state of Pennsylvania who is in a role like mine, got invited to hear about positive deviance and apply it to what was at that time in 2003 a hospital infection scourge, MRSA. In the year before, in 2002, 128 patients came into our hospital without MRSA for something totally unrelated, developed MRSA while we were caring for them, and 32 of them died. We had been trying to implement the practices that the CDC had said would work to prevent MRSA transmission in hospitals. And despite our best efforts, led by the infection control experts in the hospital, our numbers were getting worse and worse, and mortalities were increasing year after year. So we were also at the start of an organizational culture transformation initiative. And as I learned about PD, I thought, there's something about this that seems to relate to what we're trying to do across the organization with culture change. So we applied and wound up being one of the 6 institutions that were privileged to be in this project, which was sponsored by the Robert Wood Johnson Foundation. We had a big kickoff meeting where we invited literally hundreds of people to attend. We held one of them during day shift and one of them during evening shift. We told stories about hospital-acquired MRSA infections. We invited people in the audience to share their stories and experiences with that. Learned that many of them feared bringing MRSA home to their families and getting their loved ones sick, which made this a topic that felt important to them, even though largely they weren't the ones suffering because of the problem. It was the patients they were caring for. And then we invited people, if you feel like being a part of this, show up tomorrow and we'll figure out how to get started. 50 people showed up the next day, and we self-organized and started doing things, at least in a pilot fashion. Initially, 4 hospital units participated: a surgical ICU unit, a medical step-down unit, a transplant/oncology unit, and a rehab unit caring for brain injury patients. Very different populations, very different challenges about how MRSA might come in and be spread. And that's how the work began. We went around talking with people about the project in dialogues that we held with virtually anyone and everyone who could be a MRSA spreader. We began typically with nurses, But we quickly also started interacting with other disciplines, including environmental services workers and chaplains who discovered that their Bibles that they were taken from room to room could be vectors, and dietary staff who realized the trays could be sources of transmission, and patient transporters who went everywhere in the organization. Now, this was an interesting department because they were really at the bottom of the organizational hierarchy and sinking. Um, their management was talking about outsourcing this function to someone from outside the organization. One of the longtime transporters was a gentleman named Jasper Palmer, a former veteran. He had been at Einstein for several decades, and he heard about our MRSA project and took interest and started watching. And one day showed up to our Friday meeting and that we were having every other week to like oversee the work. And he said, I have an idea for something that I think could help. He had noticed that one of the problems were that probably contributed to transmission of MRSA was that people weren't putting on the gowns and gloves before they entered the rooms of people who were known to be colonized or infected with MRSA. And one of the reasons he thought that this was happening, that people weren't putting on gowns, was that the trash cans in which they would need to dispose of them were already overflowing. So he wanted to show us a practice that he had developed that I am going to share with you right now. So give me 1 second. Come on, slide. Are you seeing a video now? Can someone tell me
Yes,
if you're
but you're
Yeah,
floating in front of them.
okay?
Yeah, if you can just
All right, okay.
Hello,
got it.
I'm Jasper Palmer from the Albert Einstein Medical Center Escort Department. I'm here to show you a simple technique of disposing of isolation gowns after contact in an isolated room. It's a method that's very simple. Notice the gown has been inverted. Now I start to make a nice little ball. This prevents from air from getting in, making it too hard to handle. Nice slow roll, over and over. And observe the glove. Grasp in the middle. First one goes over the top, and the second one goes over that, creating a nice little ball that you can now dispose of in the trash can, anywhere from 50 to 150 with no spillage. Thank you.
So Jasper's idea got lots of attention. People loved the concept and started telling stories about what they had heard. Other people felt like it was safe for them to suggest their ideas too. Someone told a story about Jasper's solution to, which we called the Palmer method, to someone at a local news station, and a story ran on the nightly news locally. That got picked up by a national network, and it came on the national nightly news. So over the course of the next 2 years, dozens of solutions from the people on the front lines like that emerged. And the end result was, at the end of 2 years, our number of cases had dropped by 75%, and our mortalities had dropped by 75%. And again, all of this was through believing in the wisdom of the people on the front lines as being the source of the solutions that were needed. These conversations that we had across the organization, we called it Discovery and Action Dialogue, and this is the framework for them. What's the ideal way to do what you're trying to do? What gets in the way? The third one's kind of the key. What have you ever done or seen done that seems to make what is supposed to happen, even when that barrier is present? And then the next two are about turning that into an action if enough people say, yeah, I'd be interested in trying that. So this was our primary intervention that we did, trying to reach virtually everyone that was a potential MRSA spreader, day shift, night shift, weekends, whatever role they were in. At one of the other institutions that was in this project, their intervention was a more visual method of surfacing possible PD practices. They would do role playing and show what's supposed to happen and what gets in the way, and then start like playing around with alternatives to the norm that they would wait to see, does anyone think this actually might work, and turn out to be a better method. And similarly, at the end, someone would volunteer to try and come back and tell how it went the next time people came together. We referred to the process of listening for what could be possible PD practices as catching butterflies. And the reason we used that terminology was that you wanted to gently catch their words and hold it back up to them, and ask others, so what do you think? You wanted to catch the words gently so that you didn't crush them or say things like, oh, sounds like a great idea. Don't you think you should be trying that? So it was a very gentle, like, invitation process that at the end you were hoping that someone would choose to say, yeah, I'll give that a try. And then next time you came together, that's where the conversation would start. So here are some things that we noticed over the course of the project. People definitely developed a greater sense of community, recognizing that they were in it together, and were kind of connected with and dependent upon each other's. People loved this work. They loved being asked for what the solutions might be rather than being told. When we were surveyed by the Joint Commission, the big national accreditation organization for healthcare systems, the units that were involved in the project couldn't wait to tell them about the work that they were doing. We who were leading the project and those that were participating got used to language like, let's ask them, and that they weren't going to be told, but in fact, we were going to rely on their wisdom. The way this project spread was not because we went out looking for more units and more departments to become involved, but rather the people that were in the project told stories to their friends, and we were approached by their friends saying, we want in too. And through this kind of storytelling and social networking, new relationships blossomed, even among people who had been part of the organization for many years. This is a social network map that each of the little colored dots represents an individual, and they were asked a question: who do you go to for information about MRSA? This was at the beginning of the project, and what you can see is a hub and spoke pattern where most of the dots are connected to a single central individual, and that person was typically a titled infection prevention expert. 2 years later, at the end of the project, this is what the map looked like. So first of all, way more dots involved as many people became involved in the project. But look at this central core area. So many more people were viewed as being experts as people realized, wow, I'm kind of an expert, or people I'm working next to are kind of experts. And this is a real sign of a much healthier social network with many new relationships that had developed. Here's what I see as the special sauce of PD is, making sure that this is really a community-based effort, that you're looking for what are the practices from within this particular community. It need not be the same behavior organization-wide. It's okay to share a story, particularly not if it's someone from inside the unit that is sharing a story with someone from another unit rather than an outsider like my team was. But if a nurse from the surgical ICU shared something with a nurse from the medical ICU that was working for them, that was great. But ideally, you wanted to find what was already working from within that community to avoid that organizational immune response. We learned about the difference between ownership and buy-in, recognizing that what we really wanted was ownership. People sometimes use these terms as being synonymous, but it's not. Buy-in means someone has already come up with what they think needs to get done, and they bring it to you asking, quote unquote, you to buy into it. You may choose to do that, but you don't have to. You can buy out. And even if you do buy in, it's with the knowledge that you weren't part of the development process. In fact, they kind of excluded you from it. And so it's often lukewarm acceptance, as opposed to if you're part of the actual creation of the behavior, the solution, you've got a true sense of ownership and are much less likely to drop the practice and choose to do something else. We tried our best to almost never tell anybody much of anything, but rather ask. And if someone wasn't sure about an answer to a question that we might know the answer to, instead of just telling them the answer, we would ask them, well, maybe you can find out. And they got value from looking up MRSA statistics and separating truth from myth. We started providing lots of data about things that were important to them, and that was being used as feedback to help drive what's working and what's not working. And at the end of the day, we needed to trust the process, to truly believe that, as one of my colleagues said, we're kneeling at the feet of the experts themselves where the solutions are going to be coming from. Leaders have important things that they need to do that they're not used to doing and may be uncomfortable with, like letting go. Instead of being the chief problem solver or the source of solutions, they need to trust that it's their people that are going to have the solutions, and it's not their job to come up with the answer, at least for much of what was needed for this work to happen. On the other hand, they had an important role to remove barriers, particularly system barriers that need not have been there, that were getting in the way of the practices happening like people wanted them to. So they would go to people that the frontline folk might not have relationships with to try and remove some of those barriers. This was really the critical role, helping people truly see what was happening, holding the mirror up. Some people like to say there's what's supposed to happen, what we think is happening, and what really is happening. And sometimes they're all the same. That's ideal. But oftentimes they're three different things. And it's a job of leadership to really help people see what is truly happening, good, bad, or otherwise. And as you start to adopt this kind of leadership role, it can truly be liberating. It's like this boulder that you've been carrying on your shoulder unnecessarily is lifted off, and your job becomes easier and much more pleasurable. Here are the type of challenges for which the PD approach could be useful. They have to have been around for a while, and you've tried stuff and it hasn't worked. So it seems like it's intractable. But what PD does, of course, is kind of flip the mindset on its head and say it's not your job to come up with a solution. It's to find what's already working out there. The problem should feel big and important, like kids dying or people getting really sick with MRSA infection. So it shouldn't be a more trivial kind of problem. And the pain that it's producing needs to be real. And there needs to be some data suggesting that different and better outcomes are truly possible and are actually already happening. This does have challenges, this kind of approach. If we needed to contact everyone who was a potential MRSA spreader, that takes time. And then it takes time for the new behaviors to be adopted and to see what the outcomes are going to be. Those that are the titled experts, including the infection prevention team, they could feel quite threatened by the idea that actually someone on the front lines might know better than you. To their credit, they backed off their sense of being the experts because they appreciated that what they were doing wasn't working so well, at least for this problem. And they learned actually there were ideas that seemed to make a lot better sense than the non-evidence-based things that they were telling people should be done, at least some of the time. There was a lot of uncertainty around what was going to happen when these new practices were tried. And you have to be comfortable living with that uncertainty. And then we really did our best to provide data in such a way that the people whose behaviors needed to change owned the data. So this chart is an example of what one of the units was getting week after week. The colored lines at top represented how often they did the swabs that they were supposed to do on everybody when a patient entered the unit and left the unit. It was supposed to be 100%, and you see neither of those lines got to 100%. The dark line at the bottom was just for information, representing the prevalence of MRSA on newly admitted patients week by week. And then each of those bars represented a new case where someone had entered the unit not showing signs of having MRSA in or on them, but left the unit now showing that MRSA was in or on them, so they acquired it while they were on that unit. Providing data like this led to people kind of waiting for the data and looking forward to seeing what they were doing, and getting pride as these bars disappeared and weeks went by without any transmissions. If you're going to be a PD advocate, you need to focus not on problems, but on solutions. When people say things like, that never happens here, or it always happens this way, as Jerry Sternin would say, you need to flip statements on its head and say, really? You mean it never goes the way you want it to? Never, ever? Year after year? And people usually would say, well, every now and then. And then when that window opened, you would push to try and identify, well, what's the actual behavior that enables that to happen? Because this is truly about the behaviors. What do they do, rather than the innate skills of the people themselves. What was critical to bring into each conversation was a combination of curiosity and humility, truly believing that you weren't going to be the source of the answers, and they were. So here are just a couple things that I see as potentially relating to the work we do at Physicians Anonymous. I think sometimes in the peer conversations, you might hear people use the words never or always, and might it be possible for us to hold that statement up to the group and ask, what do you think? Is it always that way? Have you ever done or heard of it being done that it doesn't happen that way? And they can be a solution source for each other. Certainly those of us that facilitate the work that are coaches realize that the PD framework aligns with most approaches to coaching, where the solution for a coaching client is going to come from within their own values and experiences. And I'm interested to hear what others think might be ideas about how this could fit in with Physician Anonymous work. So Jerry Sternin would end his talks with this from Lao Tzu: learn from the people, plan with the people, begin with what they have, build on what they know. Of the best leaders, when the task is accomplished, the people all remark, we've done it ourselves. Thank you guys for your attention. Happy to answer any questions.
Thanks for sharing space with us at our Grand Round. A special thanks to Dr. Jeff Cohn for sharing his expertise and wisdom with us on how to identify the positive outliers to achieve extraordinary results without extra resources. Kindly like,